Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your college of entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic,
which is chronic fatigue syndrome. Now, you may wonder why chronic fatigue syndrome on the surface is part of our infectious diseases series. Chronic fatigue syndrome, or CFS, also known as myalgic encephalomyelitis, or ME, is a complex chronic illness characterized by profound fatigue that is not relieved by rest and is worsened by physical or mental activity. And it is thought that there is some infectious etiology associated with its development, as we will discuss. CFS affects approximately 0.2 to 0.4 of the population worldwide. It can occur at any age, but is most common between the ages of 20 and 40. It's most common in women with a female to male ratio of 3 to 1. And the risk factors include previous viral infections in particular, as well as stress, genetics, and immune dysregulation. So the first possible cause we are going to talk about are infections. And this usually encompasses a post-viral fatigue syndrome, often following viral infections. And the most commonly implicated infections include Epstein-Barr virus, enterovirus, and human herpes virus 6. Other etiologies include immune dysfunction, and this involves immune dysregulation with evidence of altered cytokine profiles. Neuroendocrine abnormalities have also been implicated, particularly involving the hypothalamic pituitary adrenal axis, resulting in altered stress response and lower cortisol levels. Further etiologies include mitochondrial dysfunction. Specifically, this involves reduced production of ATP, leading to dysfunction with energy metabolism. And this may contribute, as you might expect, to persistent fatigue. And finally, the last implicated etiology is autonomic nervous dysfunction. This involves specifically orthostatic intolerance, postural tachycardia syndrome, also known as POTS, and reduced blood flow regulation, which all may play various roles. Now, there have been many different forms of diagnostic criteria over the years, but the most used one is something called the Fukuda criteria. The first part of this states that there should be chronic fatigue lasting more than 6 months. That is new or definite onset, not explained by any medical or psychiatric condition, and not relieved by rest, worsening with activity. In addition to that, there should be 4 or more of the symptoms that are described at the bottom of your screen here, and these include post-exertional malaise lasting more than 24 hours, unrefreshing sleep, impaired memory or concentration, myalgia, arthralgia without swelling or redness, headaches of a new type, pattern, or severity, tender cervical or axillary lymph nodes, or a sore throat. So as you can see, there is quite a wide-ranging set of symptoms there that may be included in the diagnosis of chronic fatigue syndrome. And we will talk about differential diagnoses later, but you can see why in a lot of cases this does lead to a delay in diagnosis of this condition in many cases. Following from the diagnostic criteria, the clinical features should be quite clear to you. So these would include fatigue, which specifically should be profound, disabling fatigue that worsens after mental or physical exertion, which is also known as post-exertional malaise. There should be evidence of sleep disturbances, and this includes non-refreshing sleep, hypersomnia or insomnia, so it could be one or the other. Cognitive dysfunction, which includes poor memory and concentration issues, which some may also term as brain fog. You may also see musculoskeletal pain in these patients, which involves generalized muscle and joint pain with or without tenderness. There may also be autonomic symptoms, including orthostatic intolerances, including dizziness, palpitations, postural hypotension, and cold extremities. And finally, you may see some neuropsychiatric symptoms, including anxiety, depression, irritability, and mood swings. Based on all of those symptoms and diagnostic criteria, you can probably work out what the differential diagnosis for this condition would be and the things to really investigate for in the context of someone presenting with possible CFS. So these include hypothyroidism, anemia, diabetes, major depressive disorder, sleep apnea, fibromyalgia, which does overlap with CFS but includes chronic widespread pain, multiple sclerosis, chronic infections such as HIV and tuberculosis, as well as medication side effects such as beta blockers and antihistamines. It therefore follows that the investigations for this condition are pretty wide-ranging. There are non-specific to CFS itself, but one should make sure that blood tests are performed, including for blood count, for example, to check for anemia and signs of infection, thyroid function tests, liver and renal function tests, glucose levels, and inflammatory markers, including ESR and CRP. Sleep studies are useful to exclude sleep disorders such as sleep apnea. Neuroimaging may be of use as well, and this would of course depend on the presenting symptoms, but an MRI or CT brain scan can be useful in ruling out neurological conditions, for example, an MRI scan for multiple sclerosis. Psychiatric evaluation is also really helpful in these patients to assess for underlying mental health conditions. There are several aspects to management of patients with CFS. So the first most important thing is to suggest and discuss lifestyle and activity management. And this can include many things really. So the first would be pacing, so balancing activity and rest to avoid post-exertional malaise. Graded exercise therapy, which should crucially be under strict supervision and involve gradual increase in physical activity. Cognitive behavioural therapy can also be really helpful, and this helps patients to manage unhelpful thoughts and behaviours associated with their illness. There are also symptom-based treatments available, and these include sleep hygiene, short-term use of sedative hypnotics, for example, low-dose amitriptyline and melatonin. Pain management strategies can also be helpful, although should not be completely depended upon, and these include non-steroidal anti-inflammatory drugs, low-dose antidepressants such as duloxetine or gabapentinoids. Cognitive training exercises and memory aids can be useful. And for those patients with orthostatic intolerance, increasing fluid and salt intake as well as wearing compression stockings can also help them. As with all chronic conditions, multidisciplinary care is vital. So these patients should be referred to the relevant specialists, for example, neurologists, rheumatologists and psychiatrists, as well as integrated care teams where relevant. And this is something, for those of you revising for PACES, you will have been told time and time again probably that when you are discussing management of most conditions, it is very important to discuss the involvement of the multidisciplinary team. Most, if not all, conditions do rely upon the close working between not only different medical specialties, but also consider the role of other specialties such as psychologists, social services, and physiotherapy, just as some examples. The prognosis of chronic fatigue syndrome is variable, symptoms can fluctuate, and relapses are common. Some patients do improve over time, but complete recovery is rare. Approximately 40% of patients do show some improvement with treatment. Early diagnosis and management can help improve the quality of life. However, it cannot be ignored that chronic fatigue syndrome does lead to significant levels of disability, as well as social, occupational, and personal limitations on life. Let's now try a question. So, a 40-year-old man presents with a 9-month history of debilitating fatigue, muscle pain, and difficulty concentrating. He reports that his fatigue worsens after mild physical activity and is not relieved by rest. His blood work, including full blood count, thyroid function tests, and liver function tests, are all within normal limits. Which of the following is the most characteristic feature of chronic fatigue syndrome? So our options are weight loss, post-exertional malaise, continuous low-grade fever, hematologic abnormalities, or generalized lymphadenopathy. Now, it's really important to ask about all of these things when first assessing a patient and also checking for them when you do investigations. But you will recall from earlier in the video that we did mention that post-exertional malaise is really a hallmark of this condition, and therefore answer B in this case is the correct answer.
Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.